Everybody is online. Our speaker today is our very own Dr. Khomo. He's a specialist physician with more than a decade of clinical experience. He completed her undergraduate medical degree at the University of Pretoria and began her postgraduate studies there in 2009. In 2013, she joined Tembisa Hospital as a consultant while completing her MMed research project, which was on validity of the Wells score in predicting pulmonary embolism in our population at Biko Academic Hospital and Tembisa Hospital. From 2016 to 2017, she joined Dr. Emmanuel Taban's physician practice in Secunda, and she later assumed ownership of the practice and led it until 2022, when she sold it to pursue her growing passion for pulmonology. Her interest developed through the extensive management of respiratory patients in Secunda, particularly during the COVID-19 pandemic. And in 2024, she was fortunate enough to obtain a pulmonology fellowship post at the University of Pretoria for 2 years. And she's currently a pulmonology fellow in training, working under supervision of Dr. Taban.
Thank you, Leanne, for that introduction, and good morning to everyone. So today I'll be talking about acute management of pulmonary embolism, and particularly focusing on the new or latest clinical guideline that was published in February of this year. So just to give you an outline of the presentation, we're going to talk about what's new, the highlights, and then we're going to touch a little bit on the diagnosis that we are all familiar with, and probably the stepwise management of acute PE. And then we're going to look at risk factors, which we all commonly know. We're going to revisit the clinical pretest probability scores. We're going to look at imaging and echo. We're going to look at pulmonary embolism risk scoring, and we're going to focus now on the new categories, which is the topic at hand. And we're also going to mention a little bit on the PERT, which stands for Pulmonary Embolism Response Team, and how they basically emphasize this PERT in these guidelines. And then we're going to look at the management based on these guidelines. Right, so what is new? What are the highlights in these recent guidelines is that basically now we are moving away from the submassive and massive pulmonary emboli, and they've now tried to put these clinical groups into 5 categories, which basically accommodates most of the patients with pulmonary embolism by putting them in these 5 categories. Well, the other thing that's quite new here, and the emphasis is put on the clinical severity scores, which you would use for risk assessment. You would use both your clinical severity, not both, but clinical severity, hemodynamic status, which is very important, your right ventricular strain or dysfunction, and your cardiac biomarkers. The other emphasis on these guidelines is the usage of DOACs, which is the first strategy for most patients in especially the low categories. And the fact that the lower molecular weight heparin over unfractionated heparin is more feasible. We also, what's new here as well is the systemic thrombolysis, or well, basically not new, but the emphasis is again on systemic thrombolysis together with new data on advanced therapies. The other highlights here, as I've mentioned in the presentation outline, is the PERT, which is your pulmonary embolism response team, which is recommended for complex cases, and also clearer thresholds for lysis versus catheter and surgical options in the management of these patients. The other highlights in these guidelines was addition of the pediatric venous thromboembolic, pulmonary embolic recently updated by the ICTH or the ASH 2025 guidelines. as well as their imaging or reporting consensus of 2025. So basically, this is what's new. And I think what they've done is they basically build on, what we know already, they've built on that. And then they tried to put in, and accommodate other patients that were sort of in the gray areas. And I think for me personally, these guidelines, are better than the old ones because, most of these patients are accommodated in the guidelines. Right, so in terms of diagnosis and stepwise management, I think we are all familiar with it. Whether or not your patient is presenting to you in the emergency department or in your physician rooms or in the outpatient, as in your local clinic or your primary level care, what we usually do when we meet up with this patient is to recognize the risk factors, which we're going to touch on. We're going to basically do a pretest probability score to see whether to rule out pulmonary embolism or to rule it in, and imaging in terms of CTPA versus our ventilation perfusion scan. And I think, again, the other highlight here would be your clinical severity scoring system, which really plays a significant role in categorizing these patients. And then the clinical risk stratification scores, and which then leads us to the clinical categories and the management. So in terms of risk factors, I think we are all familiar with our major reversible risk factors, our minor reversible risk factors, and the persistent risk factors that we commonly see, especially in our setting. So in terms of persistent, we are looking at active cancer patients with or without ongoing treatment. We're looking at autoimmune diseases, and I think we can throw in our antiphospholipid here. Inflammatory bowel diseases with also high risk for pulmonary embolism, your chronic immobility there as persistent risk factors. And really, these are patients that we commonly see, especially in our setting as clinicians. Your major reversible risk factors, remember, this is in the surgical group, so very important for our surgical colleagues. Any surgery with general anesthesia more than or equal to 30 minutes falls under a very high risk group. And hospitalization for any acute medical illness for more than 72 hours while confined to the bed. And I think cesarean section and your lower limb fracture still hold quite a high risk factor. So in terms of clinical pretest probability scores, we all know them. I think the commonly used ones will be your Wells still and your Geneva and your pulmonary embolism rule in and rule out scores. But I think just to highlight the Wells again, as we remember it, and just to mention those scoring criteria there, your clinical signs and symptoms are still quite important, which then they score about 3 points. And you've got the various variables there as well, with active malignancy at the end, they scoring about a 1 point. And then after adding these points, if there are more than 4 points, then we know that your pulmonary embolism is likely and holds about a 28% risk of the patient having a pulmonary embolism. The next step would then follow on, as you see on the diagram. If PE is likely, meaning you've ruled it in based on your pretest probability scores, you would then move over to your diagnostic confirmation. And I think the gold standard is still to use our CTPA, CT pulmonary angiography. And if it's positive, you would then admit and commence anticoagulation based on the guidelines that you will choose to use. I'm going to talk about the new guidelines. All right. So if your scoring or your CTPA is negative, rather, with a PE likely diagnosis, it's often wise to just, give the patient a follow-up appointment and review them in about 6 to 8 days. Right, so just to remind us about the Geneva scoring system as well as a pretest probability score, almost quite similar to the Wells score. On the right there, that was the revised Geneva score, which was published in 2006. And in the middle, that one that just popped up would be your simple simplified rather Geneva score, which was published in 2008. And I think you can see that it's easier to use a simplified Geneva score because of it's basically your maths. If you're not as mathematic like me, it's better to use that one. So that's just the simplified Geneva score to remind us about the various pretest probability scores for ruling in and ruling out your pulmonary embolism. Just a few notes on imaging. CTPA still remains the gold standard imaging modality. And for various reasons, it's widely available and accessible. There's a reduced cost for our patients when doing a CTPA versus a VQ scan. It also holds an excellent diagnostic performance and guiding prompt management decisions. And I think the other good thing about a CTPA is that it excludes alternative diagnosis. So it really gives you a lot of data in terms of how you're going to manage this patient. And I put the lower radiation exposure there in brackets because, it's still controversial. But I think the new CT scans and the new radiation modalities that they're using now does give a lower radiation exposure, especially for our pregnant patients, because recent data has shown that there's much lower rates of radiation. It can also help you to assess the right ventricle already in the presence of a confirmed pulmonary embolism. Your VQ scan or your high probability scan, VQ SPECT, is the one that's more recommended in these guidelines. It has a greater reproducibility and specificity for diagnosis versus your planar VQ imaging that we are familiar with. And the thing about the VQ scan is that, if you can use it, in fact, the advantage about it is that you can use it in the patients where they've got a contraindication to CTPA, those with iodine allergies, and those with acute kidney injury. However, with mild acute kidney injury, you shouldn't. They usually recommend that you shouldn't hold this imaging investigation if the kidney function or the renal dysfunction is mild. But obviously, in your patients who have more than a class 3B AKI, you would want to perhaps get the nephrologist involved before giving them contrast. So in terms of our echo, so it's not a diagnostic. And remember, your echo is not diagnostic in terms of pulmonary embolism. It holds a very low specificity and sensitivity for diagnosis. However, it's very useful in prognosticating your patients. Also useful in categorizing these patients into the various categories. And as well as it gives good information on your 30-day mortality. There's data that shows that it gives you a good indication of your 30-day mortality and how your patients could fare. So the main things that the cardiologists, I think I'm mentioning cardiologists because they are the ones who are more they hold the expertise in terms of echo, cardiac echo. What they generally look for there in terms of adverse outcome would be your right ventricular dimension. So basically there your end diastolic diameter of more than 30 millimeters, or your right ventricular basal end diastolic diameter of more than 41 millimeters hold a quite high risk for adverse outcome. Your right ventricular over left ventricular ratio of more than 0.9. In your CTPA, they do mention, as I've mentioned, that CTPA can also help you to assess your right ventricle already. There, your ratio should be more than 1. Your RV-LV ratio should be more than 1 in your CTPA. And then your TAPC, which stands for your tricuspid annular plane systolic excursion, holds a quite important risk in terms of adverse outcome. And anything below 1.7 centimeters is abnormal. And these patients, you should really keep an eye on them and likely manage them in a setting or in a ward where you are able to monitor them. Your tricuspid regurgitation velocity of more than 2.9 meter per second suggests pulmonary hypertension, and then also your TDI as velocity there. So that's also your Doppler imaging in terms of your tricuspid regurgitation. I think the other sign that I wanted to mention, which is basically in the diagram there, is your McConnell sign, which is also an important sign. It's that where the airway is indicating at the McConnell sign, that is the third picture at the top. They usually call it the trampoline sign, as if your right ventricle is sort of sunken in there. There's also quite an important echo sign for patients having risk for developing adverse outcomes. And of course, there's other various signs that your cardiologist, your expert cardiology would look for. Right, so now we're moving over into your pulmonary embolism specific severity scores. And as I've mentioned earlier on in the presentation, that they really put emphasis on this. And it is an important scoring system to put your patients into these various categories. And it's quite emphasized in this. And there's about 5 scores that you can use, but I'm going to focus on the 3. And the 3 would be your PESI and your SPESI, which stands for Pulmonary Embolism Severity Index. And the SPESI is your simplified one. So these scores, they identify patients at low risk. I think that's where they come into play, and where they are important is to identify your patients at low risk. These are your patients that you can basically manage at home. You can discharge them and manage at home. They also give some pointers on your pulmonary embolism related mortality. They also, can give information on whether your patient is at risk for recurrent thromboembolism and also major bleeding risk. And they can also identify patients at higher risk groups for adverse outcomes. And as I've mentioned, there's about 5 scores, but I think the commonly used ones and the common ones that you will find in your MD calculators as well is your PESI, SPESI, as well as your HESTIA. Your others, the BOVA and the composite PE shock ones, are generally not that commonly used and not readily available on your devices. So in terms of your simplified PESI criteria, I think that's easier to use. And generally anything above 1, so you would look at those variables in the criteria. Anything above 1 deems you to hospitalize the patient. I think that's the main thing. Anything above 1 day, you want to hospitalize your patient and keep a good eye on them. The HESTIA criteria, probably easier to use, especially in the outpatient setting, for your primary care physicians as well. So it's those various questions. It's also available on your social, or not on your social, but on your devices, in your med calculators as well. You just generally ask your patient, or you ask yourself those questions. And anything, if any of these answers are yes, then you must consider hospitalizing the patient and keeping a good eye on them. So that's just a reminder on the HESTIA criteria. Right. The other emphasis on these guidelines is your clinical deterioration tool. And it is almost similar like your clinical severity scores. But this one is especially important because you can use it right through the admission of the patient. You can use it in day 1, day 3, just to see if your patient is at risk for deterioration and if the patient now deems to be escalated for management. And they generally say that in patients with acute pulmonary embolism, the first 72 hours are your major ones. So your first 72 hours, you still apply all your tools and your severity scores to see if you have to escalate a patient's management. So in terms of this, the NEWS 2 score, which stands for National Early Warning Score, it's not specific for pulmonary embolism, and it does not replace your specific severity scores for pulmonary embolism, but you can generally use it to see if your patient is about to deteriorate. So again, just to highlight that it's mainly used to identify clinical deterioration. It helps detect physiological instability. It can also be used, as I said, during hospitalization to monitor the deterioration and assist to identify patients with increasing oxygen requirements, tachypnea, hypertension, tachycardia, and altered mental state. And as I've mentioned before, that it's not designed specifically for pulmonary embolism. It's usually used in your main and other medical conditions as well. So just to give you an idea how you would use this score, I think if I go back to this, that green middle light, that's probably your stable patient, your most stable patient. As you move to the left or to the right, then you start scoring your patient. And generally, a score of 0 is saying that the patient is at low risk. So, but you still need to monitor your patient quite frequently. A score of 1 to 4 is a low aggregate risk. Here you obviously want your nursing staff to be aware of your patient in the ward, if your patient is in the ward, so that they can monitor the patient for any clinical deterioration. A score of 3 in any of these single parameters is a medium risk. And if you score this is when your nursing staff should know that they should urgently involve a clinician should the patient fall into this. Your 5 to 6, a score of 5 to 6 is a medium aggregate risk. And this is where you want to now alert your acute team, or rather start thinking about referring and escalating this patient. And a score of 7 or more is high risk. And here is where then you would involve your intensivist and get your patient transferred for escalation of management. Right, so just to give you again I think the other one didn't project properly. So this is how you would score your patient, but it is available on your devices as well. Right, so we are moving now into the new guidelines, more into the new guidelines. As I've mentioned previously, in terms of your diagnosis and your severity scores, they really do highlight this clinical categorizations and severity to recognize your patients earlier in these guidelines. So just to give you a little bit of a background here, remember in 2011, that's when your American Heart Association had published their scientific statement in stratifying your patient into low risk, submassive, and massive pulmonary emboli. And in 2019, your European Society of Cardiology published their acute pulmonary embolism risk scheme. And this is the one that I think we've been using since 2019. I think many of us are still using this one. And for instance, I had my exams recently, and one of the questions on pulmonary embolism, they were still on intermediate high risk patients. So we had to describe that. So it's still really quite commonly used because the guidelines that I'm discussing were recently published in February 2026. So remember, it's the low risk, intermediate low risk, and intermediate high risk, as well as your high risk categories. The new guidelines, which we're going to talk about now, which were published in February of 2026 by the American Heart Association and the American Colleges of Cardiology, divides your clinical categories into 5 groups, A, B, C, D, E, ranging from low risk to high risk. Just to dwell a little bit on the old systems, just so that you can see the difference in the clinical categories. Your 2011 risk stratification, which was mainly for massive, your high risk patients, your submassive, which is basically your intermediate risk patients, and your low risk. And you can see there, your high risk patients are your shock patients. They usually have a systolic blood pressure less than 90 millimeters of mercury for more than 15 minutes, or they're requiring vasopressus, right through to your low risk score where they are hemodynamically stable. And I think the middle part is what prompted our European guys to publish their stratification risk categories in 2019, because it was that middle gray area where you didn't know what to do with the other patients. And they then took that middle part and made it an intermediate risk and divided this intermediate risk group into your intermediate high and intermediate low. And with your intermediate high, you would have all three of your main risk categories positive. So meaning that your severity scoring system would be high. So your PESI would be on the 3 or 4, 3 to 5, or your simplified PESI would be more than 1. Your echo would demonstrate right ventricular dysfunction. And importantly on this one, your right ventricular dysfunction can be assessed on an ultrasound or a CTPA. Or you will also have a positive biomarker like your elevated troponin. So that would be your intermediate high risk group. And your intermediate low risk group would have one of the two positive in terms of right ventricular dysfunction and elevated troponin. Right, so in terms of our 2026 guidelines, it's quite a comprehensive document comprising of about 75 pages with 108 recommendations, and I promise I won't go through all of them. So they've assigned the level of evidence into your class 1 to class 3, where class 1 is strong recommendation, meaning that there's benefit for the patient. So if the patient qualifies, you give the treatment, or you follow the route as per the categories. And your class A level of evidence would be moderate recommendation, so you can consider it. Your class 2B is a weak recommendation if there is nothing else to give, or you have the expertise, then you could consider giving that treatment modality. Your class 3 would be no benefit. So there's class 3 no benefit, and then there's also class 3 which is harm, and that is a total no. So there's about 20 to 30 high yield class 1 recommendation in this document. And again, I'll just touch on the important ones. You can find this document in this Journal of Circulation, and you'll see, you'll just take a peek if you want the document of the reference at the end. So we are going to talk about the categories in more detail, but just to give you an idea of these clinical categories, the new clinical categories, they've divided them into 5 groups that we've mentioned, from low risk right through to high risk. So your low risk group is your patients that are not sick. And obviously your high risk group is these patients are quite sick. These are your patients that are usually requiring vasopressor support. These are patients that are pending death. And just to bring your attention to the statement below there's now a new respiratory modifier. For most of us, it's very important as clinicians. So what it basically means, so you've got your hemodynamic status or your stable patients in your various groups, but there's a respiratory modifier that's been added on. So in other words, in your category C and D, so in other words, if your patient requires oxygen, they're probably already in the category C group, right? So if your saturation is less than 90, respiratory rate is more than 30, or they need supplemental oxygen, automatically your patient falls into either the C or the D group. If they require more than 6 liters of oxygen via the nasal cannula or non-rebreather mask, they automatically fall into the D group. That is your incipient cardiopulmonary failure group. And if they now are in hypoxemic respiratory failure or ventilatory failure, they now fall into the category E group, which is your cardiopulmonary failure. And just a little bit of pathophysiology, remember with your pulmonary embolism, once you are in hypoxic respiratory failure, basically that's because of your VQ mismatch, your instability or hypertension, which is also contributing to the VQ mismatch. And they often develop atelectasis, which puts them at risk for hypoxemia, as well as some patients can also develop infarcts, which also contributes to hypoxemia or hypoxemic respiratory failure. So let's look a little bit deeper into the groups themselves. Your category A is your subclinical group. These are patients that are not ill at all. They are quite stable. Most of the time, you find these pulmonary embolism incidentally. Doing your routine scans for another indication, and there's a pulmonary embolism. They're usually asymptomatic and they have low severity scores. So if you did your PESI or your SPESI, they would have a low severity score. And basically, you can discharge these patients home on a DOAC. And just to mention and highlight that in these guidelines as well, they strongly recommend DOACs over your warfarin therapy or your vitamin K intact as a class 1 recommendation. And your category B, your patients are now starting to be symptomatic. This is an acute pulmonary embolism. So compared to your A group is incidental finding. They're not really acute patients. Here, from B onwards, you have your acute pulmonary embolism. These patients are symptomatic, but this group, they have a low clinical severity score. So in other words, your PESI would be below 3, so they would have a class 1 to 2 PESI score. And in terms of your simplified PESI, they will have a less than 1 or 0 PESI score. And basically management, they recommend that you try to discharge these patients early. They do also strongly recommend lower molecular weight heparin over your unfractionated heparin. I think that is mainly because it's so cumbersome to use your unfractionated heparin to get therapeutic and to keep it there. So, the strong recommendation as well here is for low molecular weight heparin usage. And obviously, you will then bridge your patient or swap them over to a DOAC and try to discharge them early. I didn't look at the specific groups in detail, but just to remind you that DOACs are probably better and safer in your obese patients, and your warfarin is strongly recommended, obviously, in your antiphospholipid syndrome. And DOACs and warfarin are harmful in your pregnant patients, so you would rather give them a lower molecular weight heparin or clexane. And in your kidney disease, I also didn't go into detail, but your DOACs are generally recommended. You would obviously be more careful in your late stage kidney diseases, such as your stage 4 or stage 5, and those that are on dialysis. And in terms of liver disease, your DOAC is recommended for your patients with Child-Pugh class A and B, and generally avoided in your class C. So I didn't go into detail, and I think Prof did cover it quite nicely with his last 2 presentations, and they are also quite covered in these new guidelines. Right, so we move over now to the middle group, which is your category C. And these patients are more ill. And these are patients with acute pulmonary embolism. They are also symptomatic, but they have a high or elevated clinical severity score. So whether you're using the PESI or the simplified PESI or your HESTIA criteria, they have a high clinical severity score. Any patient with a high clinical severity score, you want to admit your patient and hospitalize them and keep a good eye on them, and probably use your tool, such as your NEWS2 score, to assess for clinical deterioration. They can have elevated biomarkers and or signs of right ventricular strain. And they are divided into 3 subgroups based on biomarkers and right ventricular dysfunction. So for me personally, I think this is quite a nice or a better way of bringing most of our patients and accommodating in that gray area of the middle group where you have these 3 divided subgroups in the C category. It also stands for C for controversy because there's still really limited data in terms of these patients, but at least it has made it better for us clinicians to risk stratify the patients. So your C1, they have an elevated clinical severity score, so that's your PESIs, SPES, your HESDIA, but they have a normal right ventricle and they have normal biomarkers. Recently, we had a patient in our ICU that we admitted, a young lady. Her risk factor was that of contraceptive, so she had a minor risk factor for VTE, and she had normal biomarkers, but she had a high clinical severity score, and we opted to manage her in a high care setting for a day or 2, and then moved her to the ward. Your C2 patients, your subgroup C2, they have an elevated clinical severity score, but they have an abnormal right ventricle or an elevated biomarker. So I put all in capital letters because in C2 they must have one of either. And your C3 subgroup, they have both. They have your abnormal right ventricular dysfunction as well as your abnormal biomarker. It's generally recommended to start checking your lactate levels from this category onwards. It also, your lactate helps you to pick up your pending cardiopulmonary failure patients. And also just to mention in this, it's why it's an important group, is that still, as I said, controversy still, there was a recent study, the Python study, which shows that thrombolysis is still unclear, especially in your C3 group, where you have an abnormal RV and an abnormal biomarker. Thrombolysis is still unclear in this category. So again, C for controversy. Right, so your subgroup D is your patients that are in incipient cardiopulmonary failure. They have what we call normotensive shock. And so basically that would be, they have a normal blood pressure, the blood pressure looks good, but they have features of organ failure or a high lactate level. These are your pre-cardiopulmonary failure states or incipient cardiopulmonary failure. And they often have a rising lactate and creatinine, but you would say the BP looks good. And I think this is also an important group for me personally because you get to understand, those patients that come in with your transient hypotension and then they then respond to fluids. At least you now have where you can fit them in. And if you can fit them in, you can better manage your patients. So it's divided into 2 subgroups, D1 and D2. D1 being your transient hypertension. So these patients respond to fluids and they generally don't have any signs of end organ damage. And then your D2 group is your normotensive shocked patients. So usually they have hypoperfusion markers like your lactate, which is often, if it's above 2, it means there's features of hypoperfusion. And they can have acute kidney injury or a low cardiac index. And in this particular subgroup, you can start considering thrombolysis and other reperfusion therapies, and we'll talk about it a little bit later. In terms of your subgroup E, these are your cardio patients that are in cardiopulmonary failure. So these are really, you have very sick patients, they are in shock. And this group is also divided into 2 subgroups. So you've got your E1, which is they have persistent hypotension with cardiogenic shock. These are usually your patients that are on vasopressors. And then you've got your E2 group. These patients are in refractory shock with cardiac arrest. And just to remind us how they developed this cardiac or cardiogenic shock and death, if you look at that diagram that just popped up now, where they have decreased right ventricular contractility, decreased right ventricular output, and eventually decreased left ventricular preload, which will give you your right ventricular ischemia, and decreased tissue perfusion, as well as eventual decrease in overall systemic blood pressures because of the two pathways, then cardiogenic shock, then death. So this is just a summary of these subgroups, just put into a diagram there. And I do want to bring you again to the attention of the respiratory modifier there at the bottom, where once your patients are starting to need oxygen, they automatically fall into your subgroup C, D, or E, with E being hypoxemic respiratory failure. Now we're moving over to management, and I really like this diagram or table, and it just basically puts everything into one single picture there. As we've mentioned, your category A, your subclinical patients, you can initiate DOACs in those groups, your category A and B. And in your B, you would aim to discharge your patients earlier. The use of your clinical severity scores is still important. And these are patients with low clinical severity score. From your subgroup C1, right through to E2, we've mentioned there in the middle that you have to start measuring your lactate there to monitor your patients. Don't forget to use your clinical tool, such as you're used to also evaluate for clinical deterioration. From category C as well onwards, it's recommended that you need to do an echo for all these patients. So any patient with a high clinical severity score, you want to do an echo to assess the right ventricle. And you also want to do your cardiac biomarkers. So for any patients with high clinical severity, you do your echo and you measure your biomarkers. We've mentioned that in your categories, from your phone, you hospitalize the patient. You have to hospitalize the patient and initiate lower molecular weight heparin right through to your E category. And you can see under the E category there, you can initiate your lower molecular weight heparin, but they also recommend your unfractionated heparin there. And that's your sicker patients that you're probably thinking of your advanced therapies. You would want to then initiate your unfractionated heparin. So yeah, I think this is a nice one, putting everything together. And then just to mention quickly on your VA ECMO there, your venous arterial ECMO, that you can use in your category E2. So in terms of your management strategies in these guidelines, they strongly recommend your PET, which is also a class 1 recommendation. Remember, PET stands for your Pulmonary Embolism Response Team. I think in your first world countries, they have the luxury of having such teams on board, and it's still difficult to create such teams in our setting, whether be it in the government setting as well as the private setting. It is quite difficult, but these PET groups are really strongly recommended, and they would basically consist of your internal medicine team, your emergency physician, intensivists, your pulmonary cardiology experts, cardiothoracic surgery, which come into advanced therapies, and your radiology team, which will guide you also, and your vascular surgery team. So they've shown that they improve risk stratification of the patients. There is a diverse insight from various specialists that can be absorbed. They can also are there to educate the younger team and other specialists as well, and also advise and advise on appropriate follow-up care, and also advise and select appropriate use of these advanced therapies that we're going to talk about now, and using your evidence-based medicine protocols. This is also a nice central illustration that I got from one of the articles, and it also, in terms of management, puts it nicely into one central illustration in that circle. And as you can see, your categories A and B, your groups that are low risk, you initiate the DOAC. And then, as we've mentioned in the other diagram that we've seen in terms of management, from your category C1 to E2, you engage the PERT team, you initiate your lower molecular weight heparin, and in your E2, we've mentioned that you can think about your unfractionated heparin, especially if you are thinking about other advanced interventions for therapy. And from your D2, as we've mentioned, that normotensive shock, right through to E2, these are your patients that you can start thinking about vasopressor or inotropic therapy. And also in your E2, just to mention there, your systemic thrombolysis is highly recommended. And obviously your last resort, or rather start thinking about putting your patients on VA ECMO if they've got refractory cardiogenic shock. So this is a nice central illustration that's also helpful to have maybe on your phone. Right, so in terms of the recommendations from the guidelines, when it comes to your sicker patients, when it comes to advanced therapies, that is what we are going to now look at. So as we've mentioned, your level 1 evidence is strongly recommended. And I think in most of these advanced therapies, your level of evidence really starts from 2A to 2B. So 2A meaning consider this treatment, there is some benefit. So in your group E1 and E2, there's level 2A evidence where systemic thrombolysis and anticoagulation is reasonable over anticoagulation alone. 2B level of evidence for systemic thrombolysis is in your D1 to D2 group. So basically, you may consider systemic thrombolysis in this group over anticoagulation. And then if you look at the right-hand notes there, 3 for harm. So from your A1 to C2, your less sick patients, you should not think about systemic thrombolysis at all. And your 2B evidence in category C3, as I've said, C3 for controversy. There's still not enough evidence that supports you to give your patients systemic thrombolysis. I just tried to summarize as much as possible in terms of your sicker patients and what is recommended and what you can consider. And then in terms of catheter-directed lysis, I'll show you a diagram now of what it entails. The 2A recommended evidence where you can consider catheter-directed lysis is in your category E1. So that's got a level of evidence of 2A. So your catheter-directed thrombolysis plus anticoagulation is reasonable to prevent further clinical deterioration and early mortality. And level of evidence 2B is in categories D1 and 2. So you may start considering your advanced therapy such as the catheter-directed thrombolysis here plus anticoagulation. 2B level of evidence in category D1 and to E1. Basically here it says that you can consider it over systemic thrombolysis. So there is data that shows that there is some benefit of using catheter-directed thrombolysis in this group over systemic thrombolysis, if it is going to be beneficial for the patient. And also, I think what is important here, but also still holds a 2B level of evidence, is that you may consider it, especially in patients who have risk for major bleeding. So That's just a diagram to illustrate this catheter-directed thrombolysis. It's usually done by the interventional radiologist and even cardiologist as well. I think there are some hematologists that are also involved in catheter-directed thrombolysis. And basically what it entails, it's usually done under ultrasound guidance, where a catheter is introduced into the vessel at pressure with the thrombus itself. And you can see there's a multi-site hole catheter that will release your thrombolytic therapy right directly onto the clot and hopefully resolve the thrombus. That's just a diagram of the next one that we're going to speak about, but let me quickly just show you the level of evidence there. So in terms of mechanical thrombectomy, you've got level 2A evidence in your category E1. So that's, remember, those are your shock patients. So here it is reasonable to consider your mechanical thrombectomy plus anticoagulation over anticoagulation alone. Your 2B level of evidence is from D1 to E1, where you can consider it over anticoagulation alone. That's your mechanical thrombectomy. And just to also or rather emphasize that, you know, these are therapies that you would want someone with who has expertise in the intervention itself to do, because they hold some complications as well. And level 2B evidence in your categories D1 to E1, where you are considering this therapy, the efficacy of mechanical thrombectomy to reduce short-term fatal or non-fatal clinical deterioration and improve long-term survival is unclear in D1, E1. However, you may use it where there is risk that the patient can bleed. These will be your patients usually, you know, post-surgery, post-major surgery. Just go back to this diagram on the right, which demonstrates this mechanical thrombectomy. So you can have direct mechanical thrombectomy. As I said, it does hold quite a lot of complications. You can see it can cause trauma to the vessel wall. So hence it has to be done in quite an expert center. You can have a suction thrombectomy where they suction the clot, or sequestered thrombectomy. All right, your last advanced therapy that we can discuss that is emphasized in the guidelines is your surgical embolectomy. So that's when you would involve your cardiothoracic surgeon and other surgeon, your vascular surgeons as well are involved in this. And that's just a diagram of just demonstrate what a complex surgery it is, and should be done by experts, and it holds quite a lot of complications as well. But in the data, it has shown to have some benefit. And if we look at the level of evidence here, in terms of surgical embolectomies, your 2A level of evidence, which is recommended, is in your category E1. So surgical embolectomy, compared with anticoagulation alone, is reasonable to prevent further clinical decompensation and acute mortality. The level 2B, where the data still lacks a bit, is in your categories C1 to 2, in whom advanced treatment is being considered. Surgical embolectomy plus anticoagulation may be considered over anticoagulation alone to prevent further clinical deterioration. And maybe just to highlight there in D1 to E1, it is still unclear, but can be used to reduce the risk of intracranial hemorrhage in these groups. And in your level 3 evidence in category E2, remember your E2 is your patients that are in refractory shock, not on mechanical circulatory support. Surgical embolectomy is not recommended over other advanced therapies for preventing short-term mortality. Just to mention, if you remember in our treatment table, or the circular illustration, your E2 groups, your most sick patients, you would start considering here your systemic thrombolysis does have a level 2A evidence. So you can go ahead and give your patients thrombolytic therapy, as well as start considering your VA ECMO in this. So we almost towards the end of our talk. And this is also just a nice table to highlight your diagnostic modalities, as well as your treatment goals and treatment strategies in terms of the level of evidence. It's also a nice one to show. And green would basically say, yes, do it, go ahead, must do it. And as you see there with the orange, it would be maybe considered, sometimes unclear, and in your red categories, there is harm or potential harm. Then it's not applicable. In some of these modalities are not applicable. Like for instance, in your E2, catheter-directed lysis is not applicable. The patients are too sick, and your mechanical thrombectomy as well in E2 is not. And remember, we said surgical embolectomy is a class 3 level of evidence. It has shown harm. It has shown harm in the data. Right, just to summarize, I know it was quite a lot. As I said, it is a comprehensive 75-page document. But just to summarize what we've spoken about, so we've mentioned that in category A, or highlight some of the important issues, category A to C2, thrombolysis is harmful. It has shown class 3 recommendation. In your C3 group, your thrombolysis is still unclear. The Python trial, I think there's a recent high Python trial, which was published in April. I think the data still needs to be, in fact, not published, but I think they're about to publish it. But in your first Python trial, it has shown that lysis in your C3 group did prevent cardiovascular collapse, but at the cost of more bleeding. So that is why this is still unclear. Thrombolysis is still unclear in your C3 group. Your D1, D3 group, so your sick patients now with non-intensive shock, advanced therapies may be considered level 2A in some, and some level 2B. Your E1 to E2 group, systemic thrombolysis remains the first line, as we've mentioned, where there is no contraindication. Your catheter-directed thrombolysis, you can consider when thrombolysis is indicated, but bleeding risk is high. So remember that. So that will be mainly in your patients that are post-surgery. And then your surgical embolectomy, you can consider when thrombolysis fails or is contraindicated and there is expertise available. So that is also just, highly emphasized that you have to do it in an expert center. And just to lastly mention that your VA ECMO is reasonable for refractory cardiogenic shock in your patients with cardiac arrest due to pulmonary embolism. So just to mention a few things that were also highlighted in the guidelines, in terms of follow-up, I didn't dwell too much into it, but your acute pulmonary embolism patients, especially your provoked patients, you should, try and follow them up to a year. So follow up after the first week of discharge, and then at 3 monthly intervals till 1 year. And there you are basically looking for PE-related symptoms, if they have any functional limitations, and you want to screen for CTEPH or your CTEPD, which is your chronic thromboembolic pulmonary disease. So these are patients that are symptomatic, but they don't show pulmonary hypertension yet. And in terms of your oral anticoagulation duration, your provoked PEs, generally you can give them oral anticoagulation up to 3 months. I think most of us, you want to give up to 6 months just to be on the safe side. But generally, your provoked PE you can give until 3 months. I think Prof also covered this quite well previously. Unprovoked VTE considered to extend oral anticoagulation beyond 3 to 6 months duration if bleeding risk is acceptable, and of course with persistent risk factors, you prolong to lifelong. So these are people that require long-term anticoagulation. For patients on extended oral anticoagulation, there's a new recommendation published in your RENOVE and your EPICAT trials, where you can give these patients half a dose of DOAC For instance, apixaban, I think most of us do practice that. 2.5 BD or your Xarelto or rivaroxaban at 10 milligrams. So there is data showing that you can prevent recurrent VTE with that half a dose. Topics that I didn't cover in the presentation, which obviously need time of their own or a topic on their own, is anticoagulation special groups. I tried to touch on it a little bit, but I think the main things to remember there is your antiphospholipid group, where warfarin is still the #1 choice of therapy, and your pregnancy group, where you must try and avoid your DOAC and warfarin, as it has shown harm. I didn't touch on IVC filters, and I didn't touch on anti-factor 10A monitoring, which has become very important because most of us are discharging our patients on DOACs, especially in our special groups, your obese patients. We want to monitor them in terms of therapeutic levels of the DOAC. And then I also didn't touch on travel and pulmonary embolism. Generally, your long-haul flights more than 4 hours. That's another topic on its own. And I didn't touch on your pulmonary embolism unmodifiable risk factors, such as your thrombophilia screen. And of course, I didn't get into CTEV or CTEPD, your chronic thromboembolic pulmonary disease, which is a topic on its own. So a few take-home messages. So out with the old, in with the new. We are saying goodbye to massive, submassive PE. Remember your ESC guidelines, your European Society of Cardiology, your high intermediate, low intermediate groups that you can still use, or you can be like myself, who is enjoying these new guidelines from A to E clinical categories. I think they're very nice and not easier, but I would say, they really put that gray area of that group of patients that are in the gray area. They try to fit them in that C category. So I really like that. Your DOACs are preferred for most of our patients. So that's class 1 recommendation. And just remember, in terms of cost, your DOACs have really reduced in price. So even in our state, most patients are going home on DOAC. Your lower molecular weight heparin is generally preferred over unfractionated heparin. We touched a little bit and talked about the, cumbersome usage of unfractionated heparin. You would want to consider it where a procedure is being anticipated. And your systemic thrombolysis is still indicated for hemodynamically unstable pulmonary embolism patients. So it still holds a major role. And of course, the advanced therapies are now becoming more popular with a lot of data out there promoting them. And I think it's reasonable, but remember your level of evidence in each of your advanced therapies. I think the other take-home messages is the routine use of your PET, as I've mentioned, that in our setting, it's still a little bit difficult to have such teams on board, but where you can, it is advised to have such a team on board for especially the complex cases from your category C onwards. I think the use of integrated risk assessment in terms of your clinical findings, clinical risk scores, which are your validated scores, your right ventricular dysfunction and biomarkers still hold a major impact in our management of our pulmonary embolism patients. So thank you for listening, and those are my references. I think we can take questions. Yeah.
Thank you, Kelly, for in-depth kind of presentation. So thank you so much. And I think we actually ran out of our time. Any question online? If there's none, I think we can call it a day, if possible. And then let's get the rep time, because I think almost 8:10. And let's, but it was good. I'll ask a question later. Yeah. Any other question online, guys? Quickly. Any online question? Okay, great.